Okay, here we are. We are on chapter 7 in the emergency medical responder. This is about airway management. National EMS Education Standard Competencies, airway management, respiration, and artificial ventilation, apply knowledge, fundamental depth, foundational breadth, a general anatomy and physiology to assure a patent airway, adequate mechanical ventilation and respiration while awaiting additional EMS response for patients of all ages. These are the things that you are to be competent in, right? Airway management. Within the scope of practice of the emergency medical responder, or EMR, anatomy, airway assessment, techniques of ensuring a patent airway, respiration, anatomy of the respiratory system. Respiration, continued. Physiology and pathophysiology of respiration. It's pulmonary ventilation, oxygenation, respiration happens externally, internally, and then also on a cellular level. Respiration, assessment and management of adequate and inadequate respiration, supplemental oxygen therapy, artificial ventilation, assessment and management of adequate and inadequate ventilation, and artificial ventilation. Artificial ventilation includes minute ventilation, alveolar ventilation, effect of artificial ventilation on cardiac output. Pathophysiology uses simple knowledge of shock and respiratory compromise to respond to life threats. Medicine recognizes and manages life threats based on assessment findings of a patient with a medical emergency while awaiting additional emergency response. Respiratory, anatomy, signs, symptoms, and management of respiratory emergencies, including those that affect the upper airway and lower airway. The two most important life-saving skills, airway care and rescue breathing. The ABCs of life-saving skills, airway, breathing, and circulation. To maintain life, all humans must have food, water, and oxygen. Lack of oxygen, even for a few minutes, can result in irreversible damage and death. The main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells. There's a picture of your respiratory system. Of course, it starts with the mouth, goes all the way down through the lungs. Diaphragm is your muscle for breathing. When we had the anatomy, I think that was the same picture, but you have your nasal cavity, your mouth, your pharynx or your throat, your epiglottis, your larynx or your voice box. Your trachea is your windpipe. You have the main bronchus that splits to right and left. The carina is the point in the middle of those two. And then your alveoli are at the edge of the bronchioles. And that's where, and then the capillary is where gas exchanges. In an unconscious patient lying on his or her back, the passage of air through both nose and mouth may be blocked by the tongue. The tongue is attached to the lower jaw. A partially blocked airway often produces a snoring sound. So just opening that airway will remove the tongue off of the back of the throat there. You can see that picture. The tongue is laying right in the middle of the block in the trachea, and then when you push it back, it's open. Other parts of the respiratory system at the back of the throat are two passages, the esophagus and the trachea. The epiglottis helps prevent food or water from entering the airway. The airway divides into the bronchi, and the lungs are located on either side of the heart. Other parts of the respiratory system, the smaller airways that branch from the bronchi are called bronchioles. The bronchioles end as tiny air sacs called alveoli. The exchange of oxygen and carbon dioxide that occurs in the alveoli is called alveolar ventilation. So this is a picture of the alveoli and the capillaries, which are so deoxygenated blood is carried from the heart to the lungs by the pulmonary artery and arterioles. Gas exchange takes place at the capillaries covering the alveoli. Oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules. The lung consists of soft, spongy tissue with no muscles. Movement of air into the lungs depends on movement of the rib cage and the diaphragm. When the diaphragm contracts during inhalation, it flattens and moves downward. On exhalation, the diaphragm relaxes and once again becomes dome-shaped. So the first picture is your diaphragm contracting, and then the second picture is where it relaxes. In healthy individuals, the airway automatically stays open. An injured or seriously ill person may not be able to protect the airway and it may become blocked. You must take steps to check the airway and correct the problem. Check for responsiveness. Ask the patient. So this is the basic beginning of CPR. Are you okay? Can you hear me? If you get a response, assume that the patient is conscious and has an open airway. If there is no response, gently shake the patient's shoulder and repeat your questions. If the patient is unresponsive, call 911 first before doing anything. Then position the patient by supporting the head and neck and placing the patient on his or her back. Quickly scan the patient's chest for breathing and check for a pulse. If the patient has a pulse but is not breathing, you need to correct the airway. We've already had CPR, so some of this is we've already talked about, which is good. Head tilt chin lift maneuver is place the patient on his or her back. Place one hand on the patient's forehead and apply firm pressure backwards. Place the tips of your fingers under the bony part of the lower jaw, lift the chin forward, and tilt the head back. The jaw thrust maneuver is what you use if you suspect a neck injury. So head tilt chin lift is only if you do not suspect a head or neck injury. Use this, place the patient on his or her back, place your fingers below the lower jaw and move the jaw forward. Tilt the head back to a neutral position or slight sniffing position. Use your thumbs to pull down the lower jaw, opening the mouth enough to allow breathing. So on this one, we're not touching the forehead and we're not touching the chin. We're just grabbing on either side of the jaw there, kind of open, okay? Check for fluids, foreign bodies, or dentures. Potential blocks include secretions such as vomitus, mucus, or blood, foreign objects such as candy, food, or dirt, dentures, or false teeth. If you find anything in the patient's mouth, remove it. If the mouth is clear, consider using an airway device. Finger sweeps can be done quickly and require no special equipment except a set of medical gloves. Follow the steps in Skill Drill 7.1. And they will go over that with you when they come for the skills check. Suction machines can be helpful in removing secretions. Manual suction devices, relatively inexpensive, compact enough to fit into EMR life support kits. Insert the end of the suction tip into the patient's mouth and squeeze or pump the hand-powered pump. So this is just kind of like an adult version of what they, when babies are born, they suck the stuff out of their nose holes. This is similar, but for adults. Mechanical suction devices, clear the patient's mouth with your gloved finger. Turn on the suction device and use the rigid tip to remove the rest of the material. Do not suction for more than 15 seconds at a time. Change to flexible tip and clear out the deeper parts of the patient's throat. That's a picture of a more portable machine. That one looks like it. It's a electric one, and it has that thing on the end is called a yunker. For unconscious patients, continue holding the head to maintain the head tilt chin lift or jaw thrust position. If the patient is breathing adequately, place him or her in the recovery position. Recovery position. If an unconscious patient is breathing and has not suffered trauma, place the patient in the recovery position. Helps keep the patient's airway open, allows secretions to drain out of the mouth, and uses gravity to help keep the patient's tongue and lower jaw from blocking the airway. To place a patient in recovery position, roll the patient onto one side as you support the patient's head. Place the patient's face on his or her side so any secretions drain out of the mouth. See how they've got the leg positioned kind of up too. Okay, now we're going to move on to what we call airway adjuncts. An oral airway has two primary purposes: to main the patient's airway and to function as a pathway for suctioning. They are used in unconscious patients who are in respiratory arrest or do not have a gag reflex. So that's important to remember. You're not going to put an oral airway in somebody who has a gag reflex. This question always comes up. This is what they look like. And that's something that there's different sizes. There's a way to measure them. An oral airway can be used with mechanical breathing devices. Select the proper size airway by measuring from the earlobe to the corner of the mouth. And that's a skill that they will go over, like I said, when they come. Follow the steps in skill drill 7.2 if you want to review that before they come, which is supposed to be next Tuesday. Okay, and this is a nasal airway. So it's used both in unconscious and conscious patients who are not able to maintain an open airway. It's not as likely to cause vomiting, but you cannot suction through a nasal airway. So those are going in the nose hose instead of the oral cavity. Select the proper size by measuring from the earlobe to the tip of the patient's nose. Coat the airway with a water-soluble lubricant. The airway is fully inserted when the flange or trumpet rests against the patient's nostril. And that is skill drill 7.3 in your book. Okay, B is for breathing. So we finished airway. You can use the look, listen, and feel technique to assess adequacy of breathing. Look for the rise and fall of the patient's chest. Listen for the sounds of air passing into and out of the patient's nose or mouth. Feel the air moving on the side of the face. Normal adults have a resting breathing rate of 12 to 20 breaths per minute. Noisy respirations, wheezing or gurgling, rapid or gasping respirations, pale or blue skin. The most critical sign of respiratory arrest, which is characterized by lack of chest movements, lack of breath sounds, and lack of air against the side of your face. That's the look, listen, and feel. You're looking for chest movement, listening for breath sounds, and feeling the side of your face, air on the side of your face. Causes of respiratory arrest can be a heart attack, mechanical blockage or obstruction caused by the tongue, vomitus, particularly in a patient weakened by a condition such as a stroke, foreign objects, illness, or disease. Causes of respiratory arrest, drug overdose, especially opioids, poisoning, severe loss of blood, electrocution by electrical current or lightning. Check for the presence of breathing. Assessment of any motionless patient begins by checking for responsiveness and signs of breathing. If a patient is unresponsive, unconscious, quickly scan the chest to see if the patient is breathing. As you perform rescue breathing, keep the patient's airway open. Pinch the nose, take a deep breath, and blow slowly into the mouth for 1 second. Remove your mouth and let the lungs deflate. Breathe for the patient a second time. After the first 2 breaths, breathe once into the mouth every 5 to 6 seconds. So that's mouth to mouth. This is mouth to mask rescue breathing. Enables you to perform rescue breathing without mouth to mouth contact, and it reduces the risk of transmitting infectious diseases. To use a mouth to mask ventilation device, follow the steps in skill drill 7.4, which we went over this in CPR. You see those are the pocket masks. They're not flattened anymore. They've already been popped out, and the one-way valve has been added to the top. Mouth to barrier rescue breathing. Devices are small enough to carry in your pocket and consist of a port or hole you breathe into the mask or plastic film that covers the patient's face. Provide variable degrees of infection control. To perform mouth to barrier rescue breathing, follow the steps in skill drill 7.5. So this is just showing, how I have the little key thing. That's just a mouth-to-mouth rescue. She's got a barrier device. You can't see it very well. Requires no equipment. Carries somewhat higher risk of contracting disease. Valve mask is the big bag that we use. Place the mask over the face of the patient and make a tight seal. Squeezing the bag pushes air through a one-way valve through the mask and into the patient's mouth and nose. As the patient exhales, a second one-way valve is released.